Hello everyone. We are going to start today our review for ophthalmic, otic, and mental health medication. And today we need to thank you for all the participants today. Okay, so here we have the men health, and of course we need to talk about one of the main problems in males, especially over 50 years old, that is the BPH. What is the BPH? BPH is the benign prostatic hyperplasia. Sometimes it is the same to say benign prostatic hypertrophy. Depends, but actually both are correct. Okay, so we have androgens, and you know androgens is the big name for many subtype of many type of testosterone. So we have, for example, the testosterone itself, the hydrotestosterone, the DHT, that is very important for BPH, and the androstenedione. So all this group is called androgens. So when you're talking about androgens, we are talking of any of these three that I just mentioned. All right, so what are the effects? Everybody knows that produce masculinizing effects and secondary sexual characteristics. All right, so androgens. Androgens they have different presentations. The most common are going to be the transdermal testosterone patches, androderm, and please, this is the one who has better absorption than the rest of the presentation. We have for example, oral methyl testosterone. They're going to be not so easy to absorb because they have the, uh, the pass effect, first pass effect. What is the first pass effect? Is when the medication PO, oral medication, go to the stomach, the acid is going to decrease the bioavailability of the medication. That means decrease the absorption of the testosterone. So it's not really a good route in order to have the medication. So the best is going to be the transdermal dermal testosterone patches, and that is actually the most common. There is different other presentations like a nasal gel. We have the parenteral. We have topical gels and the clomiphene. Okay, so drugs. What is doing the clomiphene? The clomiphene, what is doing is to stimulate the is going to stimulate the production of spermatozoids. That is something that we are going to talk apart. All right, so let's keep going. So what are the uses? What is the use for androgens? The use for androgens is hypogonadism. Hypo, small, low, gonadism, gonads means testicles. So, but what is not because of the size of the testicle is related to the function of the testicle. So the testicles in hypogonadism are going to be normal sized testicles, but the function is going to be diminished. Okay, so androgen deficiency, palliation of breast cancer. So palliation of breast cancer, first of all, we need to remember, breast cancer is a sensitive cancer for estrogens. So the more estrogen, the estrogens are going to activate receptors who produce mutations on chromosome 13, just to give you an idea, that produce the beginning or the initial, it's going to start the breast cancer palliation. So if you have estrogens who stimulate these receptors, we are going to try to block those receptors with the opposite medication, that is the androgens. What is the opposite of estrogens? The androgens. Okay, give me a second. Okay. All right, so that is about, so please remember androgens, hypogonadism, androgen deficiency, and palliation of breast. Androgen side effects, one of the main important is that when you receive PO, in this case, palliation of breast cancer is PO. What is the name? Is the methyl testosterone. Methyl testosterone. Please remember that, oral methyl testosterone. And that produce intense gastric irritation. Intense gastric irritation. So what we need to do is just full glass of water. If you cannot control that, you're going to eat with some meals, with the meal. Another thing that androgens is hepatotoxicity. Hepatotoxicity. Peliosis. Peliosis is as a consequence of increase of hormonal levels of androgens. These peliosis are small areas of bleeding in the organ. So it's like a small, I will say, like a small round circle vesicles that are located in the liver, and that produce they have contain of blood. So they're small, like small dots that all over the liver. That is peliosis, and that can produce bleeding. One thing is that for some reason, cancers in general are going to take calcium from the bones, calcium from the bones. So that is, androgens are going to be doing the same. So if you have breast cancer itself take calcium from the bones. Androgens, the same thing. So if you make the summation, it's going to be hypercalcemia, hypercalcemia. Electrolyte imbalance, we have edema. Remember, please, in general, all the androgens, estrogens, testosterone, those are steroids, right? Steroids. Steroids. Aldosterone is an steroid too. Cortisol is an steroid too. So all of them are coming from the adrenal gland. So, for example, aldosterone has the property to reabsorb sodium and water. So these androgens that are steroids too, estrogens, progesterone, cortisol, they are cousins, let's put it that way, from the aldosterone. So they have not as much that potency to reabsorb sodium and water, but they have a little bit of that. So they can lead into edema. So androgens can lead to edemas. Estrogens can lead into edemas. Okay, so masculinization and can aggravate BPH. Okay, number one, we was talking about breast cancer. Breast cancer have receptors sensitive for estrogens. That can produce the origins of cancer. Okay, in the prostate in male, that is we are going to have receptors for testosterone, and this testosterone, for some reason, they are going to activate receptors that produce the increase of the size of the prostate. So BPH, listen, is benign prostatic hypertrophy. Benign prostatic hypertrophy. But they can lead into cancer, cancer of the prostate too. Okay, nursing considerations. Okay, so we have when the patient is diabetic, diabetes mellitus 1 or 2, and they are going to give androgens, they can develop hypoglycemia. Hypoglycemia. So patients who has a hypogonadism or treatment for breast cancer and are diabetic, so you need to be careful with the uh, medication. So in general, so what I'm thinking right now is if you have a patient with diabetes and taking the anti-diabetic medication, any other medication, you need to double check if there's what is the interaction of that. Androgens and anticoagulants are going to increase the anticoagulant effect, are going to increase the anticoagulant effect. Why? Because calcium. You increase calcium, calcium is part of the coagulation process, right? So the cascade, the secondary coagulation that at the end produce the fibrin. So palmetto is believed has some benefit of BPH. It's under studies. Some people recommend it, some other people don't. Doctors, we don't recommend so palmetto at all. And we have another the test that is the PSA. PSA is the prostatic specific antigen. Is a test and a digital rectal examination before initiate treatment. So they're going to, before to do the treatment, they're going to do the PCA. PCA, the normal values of PCA is going to be between 2 to 2.5. PCA has a lot of cross reactions. So if you have urinary infection, if you have some glomerulonephritis, or you have even a cold, or even any problem in the body, PSA can actually be increased. In cancers, PCA is very, very, very high. So it's making you suspicious, very indicative of prostate cancer. So PCA is, we take before the treatment. Why? Because PCA is going to help us as the baseline. So to monitor the medication later on. Okay, so treatment for BPH, we focus here, the BPH. We have the finasteride, that what it's doing is inhibit the conversion of the androgens into DHT. So if you see here, if you are going to go back a little bit, and here we have these three type of testosterone. The one who produced the enlargement of the prostate is the DHT, the dihydrotestosterone. And what is doing this medication, the finasteride, is to decrease the formation of the DHT. So we have androgens. Androgens, they have different, they are going to distribute in different pathways. One of the pathways is the DHT, and the finasteride is the one who block that production. So what happened is going to just decrease the stimulation of the DHT into the prostate. So in the long run, what is going to happen will be decrease the size of the prostate. Yes, decrease of the size. Alpha-1 blockers, alpha-1 blockers, alpha-1 blockers. Alpha-1, what is doing? Vasoconstriction, right? Alpha-1 blocker is going to do the opposite. And there's three names that we need to remember. I would like to mention the doxazosin, that is mostly used for cardiovascular problems, but the one who in NCLEX love to ask is the alfuzosin, here, alfuzosin, and the tamsulosin, Flomax. Likely, we have that in the NCLEX they put you the both names. So what is doing these alpha-1 blockers? Relax the smooth muscle of the bladder and prostate. Okay, so relax. Remember the prostate, inside the prostate or in the middle of the prostate is running the urethra. And the urethra is being compressed. It's totally decreased on diameter when the prostate surrounding the urethra is going to constrict mechanically, right? Because the prostate is enlarged. So what is doing alpha-1 is to relax the muscle that we have a layer of muscle on the top of the prostate. So this muscle become hypertrophy. And the alpha-1, what it's doing is relax this muscle. Why we have that muscle in the prostate? Okay, so that muscle in the prostate is because during the ejaculation, that muscle is going to contract. And when they contract, it's like a squeezing a sponge, the sponge with fluid. So the prostate, when that happens, is going to release the prostatic fluid. So that's why we have the fibromuscular zone in the prostate. So now, and when you have BPH, that group of muscle cells are going to hypertrophy, block the urethra, and produce that retention of the urine that we already know. I mean, it's common to see. That is, for example, you have urinary retention. You cannot pee. You pee like a very short flow, very weak. And what happens? You start to distend the urinary bladder. Distending the urinary bladder can lead into UTIs. It can lead into, remember the urinary bladder can retain 100 mLs, like a bottle of wine. And sometimes they can go up to 2 liters. And what can happen is going to many things. The urine are going to so much pressure in the urinary bladder can blow up, literally blow up. So what happened after that? Urine in your abdomen can lead into sepsis and death. All right, so let's keep going. So one thing I want to just remark here in addition is the full effect of the finasteride or Avodart. We have another one, so please, I just was trying to do this slide. So I add this, the Avodart, that is the dutasteride, teride, okay? So blocking the testosterone, teride, blocking the testosterone. Full effect in 6 months. Full effect in 6 months. Alpha blockers, we are going to have that they produce a relax of the smooth muscle of the bladder and prostate. What is the what is the goal for alpha 1 blocker? We're talking about urinary retention, right? So what it's going to do is to make the increase the urine flow in male who has this problem of BPH. So urine. So make the patient pee, in other words. Do not affect hormone production. Okay, so this do not produce, so it's going to affect only this do not decrease the hormonal level. Is going to relax muscle and produce the urine. Side effects. Pay attention to this: dizziness, headache, and lethargy. Alpha 1 blocker. Dizziness, headache, and lethargy. All right, so danazol is for women's health. So that was being seen in Pharmaco 1. Okay, so let's go to the eye. Eye. How many letters we have in the eye? 3 letters. I-Y-E, right? So 3 letters, 3 chambers, three layers. The 3 layers: outer, sclera; middle, choroid; and the inner is going to be the retina. So 3 layers. And the chambers are going to be what? The anterior chamber, all this blue, anterior chamber between the cornea and the iris. Can you see the iris here? This is the iris. This is an anterior chamber. This area, who is very narrow, very thin, and you can see here, that is the posterior chamber. Okay, the posterior chamber. In the posterior chamber, we have here the lens, and posteriorly to that we have the vitreous body. Vitreous body is a gel. This blue, more clear, is the aqueous humor. So aqueous humor is going to just let's put it this way, or surround the lens, the iris, the cornea, between the anterior and the posterior chamber. So here we have on the top here the ciliary body. And that is, talking about eye, we need to talk about pharmacology of glaucoma. That is one of the most common causes of blindness in the United States. So we have here the ciliary body, and the ciliary body is a complex of structures. Ciliary body is equal to, say, ciliary glands plus ciliary muscles plus ciliary vessels. From these 3, we are going to just stay with the ciliary glands. Here are the ciliary glands that are part or is a component of the ciliary body. Okay, so here we have in the ciliary gland, here is where we are going to produce the aqueous humor. So aqueous humor, just to mention very fast about glaucoma, aqueous humor is going to, if you have too much aqueous humor, imagine you have too much aqueous humor here, and here. What happened? Lens is going to go back, going to be pressed posteriorly, right? Because more pressure here go in this direction. Then what happened? The lens is going to press the vitreous body. Vitreous body is a gel. That is going to distend the walls of the eye, so that's why glaucoma is going to lead into what? Pain, ocular pain. It could be uni or bilateral. And or it could be different intensity or from the right or and the left. So this glaucoma, what they are doing is at the time you're moving your eye, you're moving right or left, up and down, the gel in so much tension is going to compress the retina. And when you move your eye, you will see that there's some flashing, some lights that appear according when the aqueous vitreous body is going to just make friction with the retina. All right, so going to the point here, we have that this pressure is going to compress the optic nerve. Compressing the optic nerve, that is the retina is the continuation of the optic nerve. Just imagine this as a 3D. So it's not like a line. It's like the whole lining of the eye is covered by the retina, and the retina is a projection of the optic nerve. So this pressure is going to, here, how many nerves we have? One, two, three, we have thousands and thousands of nerve fibers. And these fibers, with that pressure, are going to die one by one. So progressively, they are going to start losing his vision. Number two is that medication for glaucoma is for lifetime, need to be for the rest of his life. So that means that you cannot run out of medication, not even one day. Okay, why? Obviously, we are going to have the intraocular pressure is going to be increased. And we are going to see that in a few moments. Okay, so here's another view. Let's make it faster. Here we have, this is the iris, this is the ciliary body. Here's, we produce the aqueous humor. But there is one thing here I want you to see, this opening. Can you see this opening here and this opening here? That is, the aqueous humor is produced by the ciliary body or ciliary glands. They are going this way and they are going to drain. So there are going to be an excess, if there is an excess of, normally if there's an excess of what? Of aqueous humor, they are going to drain through the Schlemm canal. The Schlemm canal here is going to continue to the venous system. So we have, for example, open glaucoma and closed glaucoma. Open and closed glaucoma. And open glaucoma is that you have this area, the opening of the Schlemm canal is permeable. But what can produce that increase of intraocular pressure? Because probably too much production. Okay, so one of the, for example, is going to be narrow but not totally blocked. That is going to decrease the excretion of the aqueous humor into the venous system. That is the open. And the close is when this um, ciliary irido angle, or this angle you see here, is totally closed. So this process, iris is going to be, this area is going to be totally blocking the Schlemm's canal. So which one is worse? The one who is totally blocked. All right, so let's keep going. Here we have the Schlemm's canal. It's called the meshwork. It's the Schlemm's canal. And here's the ciliary body producing aqueous humor, go this way and then the other way. Okay, so here we have a narrow angle and open angle. So you see here the open angle. So this increase of IOP, intraocular pressure, when the Schlemm's canal is open, right? It could be for too much production of aqueous humor. And here we have the narrow angle or closed glaucoma. So it's going to be totally blocked there. And you see the iris, okay? It's called the iridio-corneal. This is the cornea. This guy is the cornea. Iridocorneal angle is going to be blocked. All right, so let's go to the point now and let's see. This is a summary that we already know. We already been talking about the Schlemm's canal, so please remember that, Schlemm's canal. We are going to see the glaucoma. What is glaucoma? First of all, you need to know what is the normal value of the intraocular pressure. Intraocular pressure. The normal value is 10 to 21. 10 to 21. 10 to 21 millimeters of mercury. Okay? All right, so we was talking about glaucoma, closed glaucoma, open glaucoma, and the primary causes are actually closed and open glaucoma. Secondary is caused by accidents, trauma, some mechanical forces that can produce, or injury. Even cataracts can lead into glaucoma. Okay, so nursing considerations, don't run out of medication because they can be a rebound effect. Okay, here you can see the administration of the medication in the conjunctival sac. So put it in the inner layer, in the inner side of the eye, and you need to press the inner side of the eye in order to prevent the exit of the fluid. So it's going to have longer time contact with the eye. All right, so okay, so let's keep going with the miotics. Miotics are eye drops that stimulate the parasympathetic nervous system, causing the pupil of the eye become smaller. In general, they can make some changes uh, uh, um, in the drainage or production of the aqueous humor. All right, so let's talk about the adrenergic. So if you are scared, if somebody try to make you a joke or surprise, you start to have a lot of adrenaline. Your pupils are going to be start increasing in size. So that is called mydriasis. Okay, mydriasis is one of the action of the adrenergic agents. So we have the clonidine. So APRA, clonidine. Remember clonidine? Clonidine is an alpha-2 agonist, and brimonidine, so nidine, clonidine, nidine, brimonidine. So all these are adrenergic. So what they are doing is doing the increase of the outflow of consumer. I have the mnemonic at the end that is going to help you. Okay, so let's do the beta blockers. We have the beta blockers, the timolol, levobunolol, cartiolol, lol. All these guys are going to produce the decrease of the production of aqueous humor. All right, so just remember the beta blockers, they can be, when they are being absorbed. So why you need to know this? Because they can be absorbed by the systemic system. So, and that can produce side effects of beta blockers. In this case, be careful with the bradycardia. Cholinergic. So we have A, we have B, we have C now, is the pilocarpine, is the most common. And this is a cholinergic effect. Just remember, cholinergic effect produce meiosis, means little pupil, or mydriasis. Remember that what is the opposite, let's put it, the opposite of sympathetic is the parasympathetic, correct? The opposite of sympathetic is the parasympathetic. Who is the sympathetic? Adrenaline. Who is the parasympathetic? Cholinergic. When you are scared, anger, or excited, you release a lot of adrenaline, sympathetic, correct? So your pupil is going to be dilated because you need more light in order to see things. So mydriasis is going to be adrenergic. And the opposite, cholinergic, just to remember, is going to produce the meiosis. Okay, so let's keep going. All right, so I want to go, we have another one that is the ecotiophate iodide, that is a cholinesterase inhibitor that is going to increase even more the cholesterol levels at the level of the synapses. We have diuretics, carbonic anhydrase inhibitors. This is very typical question. Carbonic anhydrase inhibitors, we have the Diamox. The Diamox. What it's going to do is to diminish the production of aqueous humor. Acetosolamide, remember acetosolamide, metasolamide, solamide is going to be carbonic anhydrase inhibitor. We have prostaglandins, and the prostaglandins we have the bimatoprostaglandin, no, bimatoprost, that is prostaglandin. And what it's going to do is increase the outflow of aqueous humor. All right, so in NCLEX, what they are going to do is this. That is a summary of this lecture because that is mostly the questions that are coming. We have A, B, C, D, P. So we are talking about glaucoma, correct? Okay, so we are going to see that there is two options. One option is to increase the intraocular pressure happen when you have too much production of aqueous humor, or you have too little drainage. So too little drainage or too much production. That can produce the increase of IOP. And that's what they're going to ask you. So just remember A, B, C, D, P. A is for adrenergics. They're going to decrease what? Decrease the drainage or decrease the production in order to treat the glaucoma. You need to have the decrease of the production. B, again, is going to be the decrease of the production. So beta blockers. We have the diuretic, the acetosalamide, for example, that is going to decrease the production. And we have the cholinergic. See, cholinergic is going to be increase what? The drainage of the aqueous humor. And the prostaglandin doing the same. So C and P. Okay, so A, B, C, D, and P, and that is the easy way to remember the mechanism of action and what they like to talk in the in NCLEX. Mannitol, we have mannitol. The mannitol is going to be is a carbohydrate that is so big molecule they cannot be passing through the capillaries, so they stay in high concentration in the capillaries, pulling water from the tissue into the vascular system. So that is going to use for glaucoma too. So what they're going to use is they are going to decrease the production of the aqueous humor. Anticholinergic. So this, remember, don't get confused. A, B, C. A, B, C. C was cholinergic. That's for glaucoma. This is anticholinergic. So we don't use anticholinergic for glaucoma. It's the opposite. Okay, so this mostly what is doing this. Again, cholinergic is doing what? Meiosis or mydriasis? Meiosis, right? So if you give anticholinergic, it's going to promote the mydriasis. And what we do this is the eye drop that they put in the eye in order to dilate your pupil in order to observe what is going on inside. That is in the optometrist. Antibacterial, we have the tobramycin, bacitracin. Those are actually antibiotics. Mostly they are bacteriostatic. Tobramycin is going to be a bactericide. Antifungal, we have the natamycin, and always when you have, they can produce photophobia. In this case, it's photophobia. Antivirals, the same thing. So remember, antifungals, antivirals, if you take antivirals, antifungal for other reasons, you need to look for liver, for hepatotoxicity, nephrotoxicity, and photosensitivity, right? But these side effects are going to be minor because you are using the eye, and the eye is not going to absorb huge amounts of this medication. Okay, so I think that is for today. We are going to do a very much more detailed summary on Thursday. So I sent an email to everybody already. So please, I would like you to really tell me what are your areas of weakness, and we can start talking about and develop questions and roundtables. I promise it's going to be very productive, very straightforward, and answer the questions. And please, I want you to prepare your material for that Thursday. Again, it's voluntary. All right, so let me see here. Just a moment. Who was here? Okay, just a moment. Arisbeth, thank you so much. David, hey, how are you? So thank you so much.
Thanks, Dr. J.
Joanne, hi Joanne, how are you?
Hi.
Monica, Shelby, thank you so much for being present today. I will record it. This
Thank you, Dr. J.
simple webinar, as you can say, is I'm going to record it and post it, and you will be able to. Remember, this is our last webinar, Uh, so any questions, just let me know. Okay. Okay. Have a good night, everybody, and thank you. Any questions?
No question, Dr. G. Thank you.
Just thinking. What?
No questions.
Okay. Thank you. I like that. Have
Thank
a
you,
good
Dr.
night,
G.
everybody. So, bye, Shelby.
Good night.
Good
Thank you,
night.
Dr. G. Good
Thank you.
night.
Thank you, everybody. Thank you. Bye.